Hi everybody, we're back. That was part 1 that we had. We're going on to part 2 of chapter 25. With the other one kind of like, I want to try to do it in pieces like we talked about before. So with the intramuscular, we're talking to another thing about before we started in part 1 is that you want to make sure that you have them relax the muscle that you're going to give the injection in with the intramuscular. For example, like the vastus lateralis, which is the thigh area, you're going to want to make sure that they either in a sitting position or lying supine with their knee flexed, like a rolled blanket under their knee or towel. That way we relax the muscle and it's easier for them than the medication to absorb the way we want to. All right, next we want to talk about intravenous. With IV medication, it's usually can be a continuous infusion or ones that we just want to give the medications for, just like over a half hour or whatever. So they might have just like a PRN adapter. They call it site as needed adapter site. And the needle gauges also will, of course, be of different sizes. It's on that page, as well as the needle lengths. With injectables, like when we're giving intramuscular, back to intramuscular, you want to make sure that on page 806, you look at the pieces and parts of the medication, the needle and syringe. You definitely want to always avoid touching that plunger. Keep your fingers off of the plunger itself. You want to use, when you're drawing it up, that springboard at the bottom there, that little handle in the top of that handle of at the bottom of the barrel when you're pulling it up. And definitely don't touch the needle at all. IVs, you're going to make sure any type of injections, you're going to wear gloves. But the IVs, when we're the medication or the needles and all, you got to keep those sterile as well. All right, sometimes people have what we call ports, central venous access ports. With the central venous access ports, you want to make sure you know the policies on them, how to flush them, that ask if they've been accessed, that you have permission to access those sites, we can draw blood from those things, we can give medications from those sites, and we want to make sure that we maintain that we don't get them infected or anything as well. So we'll wear like a mask usually on some of the central sites when we're changing the dressings and sterile gloves and all that. I had a student trying to access a pacemaker before, which is not a good thing to do. It can cause serious damage. So make sure that it's actual a site to be accessed. All right. I did want to put that. And some other things with the IVs, I want you to know some lingo, some language. With IVs, they can get infiltrated. You always want to check the site to make sure it's not getting swollen, not getting red, not getting painful in that area, that it's infusing correctly. And with children or infants, we're very careful on how much volume when we're measuring it that we give in. Sometimes we use something called a Buretrol, which is like a little tube that we connect to the IV tubing, and we only allow a certain amount to be infused at a time, and then we check frequently on that. As we get older, we definitely also should be checking your IV sites. Oral medications, usually if they're going to have an effect, and just depends. All meds are different. The onset's different. So know your onset and come in and check it. But usually with oral, it'll be like within about a half hour. We'll check it 20 to 30 minutes later after giving it, unless the onset of the medication is quicker. And then with injectables, it's usually within that 5 to 15 minutes, because remember, that's directly to the bloodstream. It can cause a fast effect. All right, so some terms: infiltration. Infiltration is when the fluid of the IV doesn't go into the vein. It seeps underneath into the skin area. It gets inflamed or swollen. It's cool to touch usually. It'll slow or stop the infusion. Your skin will be taut, which is tight feeling, and it'll be painful. So in an infiltrated site, you're going to want to stop the site, of course, put a compress on it, and then notify the physician, and don't restart in that area another IV if they need one. Always notify and document. The next one is phlebitis. Phlebitis would be due to maybe a surface little blood clot or something stopped it. It gets sore, it gets tender. It's also taut, tight, but it's warm, not cold to touch. It's usually hot to touch and swollen and all. And that's usually due to a blood clot forming. The area is red, and so you want to notify the physician as well and stop that. Extravasation, extravasation. Extravasation is like an infiltration, except it's an infiltration of toxic caustic medication to the skin and tissue, and it can kill the tissue in very quickly. You can lose your arm or leg or wherever the IV site is. It's really bad and it's painful. It's burning. You want to stop it immediately, and then make sure you know your policy. Sometimes we don't take out the IV because they want you to try to aspirate or pull back as much as you can with a syringe first. Sometimes we'll inject what we call an antidote. If there's a medication that has an antidote, meaning a medication that'll stop or decrease the effect of the bad effects of this medication in the skin, we'll give that. And then we'll remove the IV. So you do have to know those lingos or languages. With extravasation, like I said, it's very painful and all. And I also draw like a circle with a pen around the site to see if it's getting worse or if it's getting better. That's another thing that I wanted to mention for you. All right, based off of, we were talking about antidotes. There are some antidotes to medications, whether it be IV, oral. Since we're on this site, I said, what the heck? Let's just throw in some antidotes for you to know. You got to know them anyway. Let's start while we're little younglings, right? Little nurslings. So some antidotes I want you to know is when we give heparin, the antidote for that is called protamine sulfate. Protamine sulfate, sulfate. When we give warfarin or Coumadin, remember the anticoagulant, for heparin, we check their APTT levels, or PT-APTT levels. With vitamin K is the antidote for warfarin or Coumadin. That we're going to check their INR and PT levels. So warfarin or Coumadin, the antidote is vitamin K. Okay, if somebody comes in with an acetaminophen, or also known as a generic for Tylenol, overdose, which is really bad. It's over time, it kills the liver. So acetaminophen, acetaminophen, overdose, or been taking way too much, like more than 2 grams of Tylenol as an adult in a 24-hour period. Don't want to do that. They can overdose and hurt their liver. So an antidote that we'll give for those is something called acetylcysteine, ACETYL, cysteine, CYSTINE, also known as Mucomyst, MUCOMYST. We used to give this sometimes for people that have lung problems, like with my asthma when I was young. I used to take this Mucomyst through an aerosol, and it stinks like rotten eggs. You'll never forget the smell. All right, the other one is with opioids. Opioids. We will give naloxone, NALOXINE, or Narcan. Your opiates are like heroin, morphine, those kinds of things. Narcan is a good opiate buster. Okay, if somebody's on digoxin, DIGOXIN, also known as Lanoxin as the trade name, LANOXIN, we will give something called digoxin fab, DIGOXINE, fab, FAB, or Digibind, whatever you want to call it, DIGIBIND, Digibind. Lanoxin, you got to know frontwards and backwards. It's a medication that we do to regulate heart rate sometimes with people that have heart problems. And with this one, you want to know like labs, which you're going to look up eventually this semester, don't worry, like potassium and all. And you need to check an apical on them, because if their heart rate is, and for a full minute, the heart rate is less than 60 or greater than 100, you're going to want to make sure that you report that right away. And the last but not least, and there's other ones, but I'm not asking you to be responsible for them, is when we take anticholinergics, ANTICHOLINERGICE, or CS, also the anticholinergic meds, we will give we can give an antidote called physostigmine, PHYSOSTIGMINE, physostigmine. Okay, and that's one of those antidotes that we need to know. Okay, so I'll give you a list of those, but that's what I want you to know as far as the list for any testing. Alrighty. I've got one more question I wanted to give you, and that is the nurse must administer a medication 0.5 milliliters intramuscular to a 3-day-old infant. Which injection site would the nurse choose to administer that medication? So it's a 3-day-old infant, 0.5 milliliters intramuscular. Which site would the nurse choose, the best site, to administer the meds? A, ventrogluteal, B, vastus lateralis, I'm sorry. C, deltoid, or D, dorsal gluteal. So would it be A, ventrogluteal, B, vastus lateralis, C, deltoid, or D, dorsal gluteal? Okay, that's your last question. There's 6 of them now. Alrighty. When you remember choosing a subcutaneous needle, back to the injectables, it says make sure that the needle gauge insulin uses often a more finer needle versus the other ones were more typical 25 to 27 inch. And if you can pinch more than an inch, you go 90 degrees. One more time, the thinner, I know I said this already, person will use it at a 45-degree angle. Just got to get that in your heads. All right, some other things with IVs, sometimes we have to add medications to them. We can do pushes. If it's ordered as a push, we need to know how many minutes that we do the push. Sometimes it's going to be like more than 10 minutes. I'm going to put it in a bag and drip it at that time in there as a piggyback. When we do secondary piggybacks, that just means we add a medication in a smaller bag above a primary site. And you'll learn that when we, through videos and stuff like that, what that is. We call it a secondary or a piggyback medication, antibiotics and stuff like that. Alrighty. And of course, you'll learn much more about IVs next semester. All right, there are some things called pre-filled unit doses that we give. You're going to be giving them a lot, usually on a med-surg unit. Sometimes we give Lovenox. That's a trade name, also known as enoxaparin, enoxaparin, enoxaparin. Lovenox is given, Lovenox, for people that are usually up and moving and now aren't, and they're more apt to getting a clot. So we will give them Lovenox. We give it in the abdominal area. We give it subcutaneous, but it's already pre-filled. When it is pre-filled, it has some air in there. Do not push out that air, because that air is intended to make sure that when you put it down, the needle side down, the air rises to the top, and that after the medication's injected, that air, the purpose of it is to make sure that all the medication got injected in there. Because if you pull back up off the needle and you don't have the air in there, you could have some of that fluid on top at the tip of the needle when you're pulling back and cause the bleeding in the tissue. With deeper IM medications, I always draw back about 0.2 of air in it and have that same idea as the air will push in the rest of the medication. They don't always do that anymore. As a matter of fact, they don't encourage that anymore like we used to. Their idea is it will push through anyway, but with deeper IMs and those pre-filled, yes, do not excrete that air. That's what I do. Okay, the other thing is we have sometimes medications that are in the vial that we showed you, like that morphine and stuff like that, that we have to use that plastic. We can use that plastic device. It's called a carpuject, that you screwed it in place. If you don't remember, let me try to show you the picture here. But the carpuject was one of them. Anyway, you had to... we showed you how to screw it in and use it. Sometimes penicillins and stuff like that come like that. I just plop the top of the needle off, and drop my own on there. Do not drop air and shove it in those pre-filled cartridges, or you're going to have the screw coming out the back end and shooting medicine everywhere. Just remember, I learned well off of that. Remember, always wear gloves. When you are shaking the vials, they tell you not to shake, but to roll it between your hands. That's one thing that you're going to make sure that you do. And then with mixing the medications, you're taking care not to create any bubbles. So that's why you roll it. You will always wipe off the toppers of them with alcohol. And when you're drawing up air to inject in to the thing, you're going to want to make sure that you draw up the amount of air that you're putting in the bottles of vials before you pull it out. Air creates pressure, so it comes out easier and less bubbles. But when you're putting air in, you're drawing up the amount of amount of air equal to the amount of medication you're going to give. Okay. Next, we want to talk about the ampules. The ampules are those glass bottles. You want to make sure you use a filter needle when you are drawing up medication from an ampule that you just broke. When you're drawing up the ampule, or when you're opening the ampule, you'll open it up. You have your gloves on. You're going to use a little gauze or alcohol swab or an ampule breaker. They have actually commercially made ampule breakers to break off that tip, not your bare hands. Use the filter needle when you're withdrawing needles. I do that with all my medication. I use a filter needle. Just remember that you change the needle after, because if you're giving an intramuscular, you can give a nasty little biopsy and take some skin with it, because it's a big thickness to open pore needle there. Filter needles are very too large to be injectable, as just an FYI. So with the filter needle, you withdraw anything that you take out of an ampule for sure, so you don't get any glass in it. And then always change the needle and hold the syringe vertically when you're going to inject the air until you see a drop of the medication at the tip of the needle. All right. Next, we wanted to talk about mixing insulins and insulin. So with insulins, the rule of insulin is that you never, ever mix long-acting insulin in the same syringe as other insulins. So your long-acting insulins, for example, are Lantus, Levemir. They start with L, so I know those are longer acting. They just have a incompatibility with other insulins. You can give it at the same time, but you can't use it in the same syringe. So if you're ordered, say, Humulin R insulin, which is a regular insulin, fast acting at 9 p.m., along with Lantus, which is long acting, 9 p.m. as well, you're going to give them both at the same time, but you're not going to, like, you'll inject one in one area and then inject the Lantus in the other. You just don't have them both in the same syringe. Okay. You should know your insulins. I need to, and I can give you a paper on that as well. With regular insulins, they're short acting, they're usually within about 15 to 30 minutes they react. Your rapid insulins, or fast acting, I mean. Your rapid insulins are like your Novalogs. They happen in 5 to 15 minutes. Your NPH is your intermediate insulins. Those usually around 6 to 12 hours. Your long insulins are usually about 12 to 24 hours. So those are some examples of some insulins. You want to always make sure the client is eating usually, or has something at the bedside, a snack that they can have, like graham crackers or something like that, or a meal at the side when you're giving rapid insulin or Humulin R insulin, because of the fast way it reacts. If they are vomiting and not eating, you want to notify the doctor, take a sugar, notify them what the insulins are, what their sugars are before giving them their insulin. He might have to change, or she might have to change the dose. All right. The next thing I wanted to teach you is about when mixing insulins. So sometimes the physicians will ask you to mix the insulins, and regular insulin is clear. NPH, intermediate insulin, is cloudy. So how I remembered is the mnemonic the initials RN. R for regular, N for NPH, or I just think in my head clear to cloudy. So that's what we drop first, is clear, then always the cloudy after. You roll your insulins, you don't shake, just so you know. You wipe off the toppers, and you're going to draw it up first the clear, then the cloudy. But when you're doing air, you put in the air in the cloudy first, then in the clear. So let's give you an example. You were ordered Humulin R insulin, 10 units, and NPH insulin, which is an intermediate insulin, 10 units. So you're going to wipe off the toppers. Of course, you checked your thing. You got your gloves on. You're going to wipe them off with alcohol. You're going to pull up 20 units of air. You're going to inject 10 into the NPH, which is the cloudy insulin first. And then you're going to remove the syringe and then inject the rest of the 10 units of air into the regular. You're going to then, without removing the tip of the needle out of the regular bottle, you're going to flip or invert the bottle upward, and you're going to pull out 10 units of air, making sure there's no bubbles. Then after you get the 10 units up of the regular, you're going to pull it out, then draw up the 10 units of the NPH. Remember, the air helps pull the pressure out so there's less bubbles, and that's why we do that. Only use insulin needles for insulin. Remember that heparin you'll put in a tuberculin needle. Yes, they're both in units, but the heparin will be measured out in milliliters. Okay. You can do that too with IV insulin and all that, but that's when we get into that, we'll talk about measuring that. But when giving insulin sub-Q, you always put it in, or any type of insulin, you're going to draw it up in that, okay? All right, let me make sure that we got everything on there that needs to be. You didn't forget anything before I let you go. Don't forget, you will have another assignment due. The reason for it is if I'm only giving you an hour and lecture, and lab is very interactive, you have to be able to spend 2 hours of that time doing interactive things. All right. And if you have questions, let me know. And I'm getting that ATI questions fixed like I talked to you about from the pharmacology questions that I'm working on. All right, I think that should be it. And remember, on the back of the chapter talks about all these wonderful things that we did, about the angles and stuff like that. I did give you the best I can of the page numbers. I know like in the 874s and all, it talks about administering IV push medications, administering intermittent devices with extension tubing and stuff like that. Please read over those. Do watch the videos. I will have questions for you on, to have you answer with the videos too, like writing a little thing about that. So you'll get the assignment on there, and that should be it. Remember that these 2 parts is the same video. It's just we had to break it up in 2 parts. And this is of chapter 25, the parenterals. And they will be all due your assignments next, or this Friday, this Friday. Okay, have a good week.